So good evening, everybody, and welcome to the second of our kidney health webinar series. My name's Anne-Marie Swoboda. I'm a GP and I'm the Medical Director of the GP Liaison Unit for Canberra Health Services. Before we begin this evening's session, we wish to acknowledge the traditional custodians of the land on which we're meeting today, the Ngunnawal people, and we wish to acknowledge and respect their continuing culture and the contribution they make to the life of this city and this region. And we'd also like to pay our respects to their elders past, present and emerging. And we'd like to acknowledge any Aboriginal and Torres Strait Islanders who are joining us for today's session. So just a little bit of housekeeping before we get started. Please keep yourself muted. There'll be plenty of time for you to ask some questions, and we encourage you to put some questions into the QA and chat function. I'll be monitoring your questions and comments as we go, and Tom will be answering those as we go along at the end of the session. We'd also like you to complete the evaluation at the end of this session, and also please remember to put in your RAC GP number so that we can log your CPD hours for you. So this webinar series is focusing on the spectrum of kidney health. Our first webinar was on hypertension and acute kidney injury, and today we're going to be focusing on chronic kidney disease, really important topic for our GPs. So I'd like to introduce now our presenter, so Tom Lea-Henry, who is a renal physician here at Canberra Hospital. He joined us in 2024. He's a clinical scientist and a McMaster Research Fellow at the ANU. Tom, I'll let you take over.
Thanks, Anne-Marie. Okay, today we'll be doing chronic kidney disease, and I'm concentrating predominantly on the management of chronic kidney disease, both in terms of reducing the risk of progression, but also managing some of the complications that arise in patients with chronic kidney disease. So, here we go. So this is what we're discussing today. I'll go over a bit of background on CKD, and then there'll be a sort of a case-based discussion around CKD development and management. And then there's a little section on the management of sick days in people with CKD, because many of these people have significantly increased risk of acute kidney injury arising from their kidney disease, but also many of the medications that we prescribe them to help reduce their CKD risk. And on top of that, I'll do a short section there managing some of the complications of CKD, like hypophosphatemia and anemia of chronic kidney disease. So in this first slide, we're talking about why CKD is really important. And in terms of CKD risk, the risk of progression, obviously the worse your CKD is at the time of diagnosis or whatever time you're seeing the patient, the increase the risk that you will develop end-stage kidney disease. And so in this study, what they did is they looked at people who were either stage 3 CKD, as you can see at the top, stage 4, or stage 5, not requiring dialysis. And they then monitored them over time to see how long they managed to remain free of dialysis requiring CKD. And you can see with the stage 3 CKDs, almost everyone was dialysis free at 8 years, with some people progressing. Stage 4, somewhere in the middle there. And pretty much everyone by 3 years was dialysis requiring in those with stage 5 CKD. So an estimated GFR of less than 15 ml per minute. And so really what this tells you is obviously the obvious thing, that the worse your CKD is, the higher the risk that it progresses to more advanced CKD. And CKD severity is important because not only does it predict your risk of developing CKD, but it's an independent risk factor for cardiovascular and all-cause mortality. So there's this markedly increased risk as you go down the CKD severity curve of death from any cause. And often this isn't actually CKD related. The most common cause of death in the CKD population is cardiovascular mortality, which is why we'll kind of focus on this down the track. And you can see that there's actually this relationship between the risk of death and an inverse relationship with your GFR. And in fact, the curve on the left is a logarithmic scale. So you can see as your GFR progressively declines below 50, your risk of death from any cause markedly increases. And when we look at the Australian population, so this is from the ANZ data annual report. So this is data collected on people in Australia with advanced chronic kidney disease, dialysis or transplantation. And what you can see is when people become dialysis requiring, they have this markedly increased risk of death relative to the non-dialysis population. So on these two graphs, we have a male and female on the left, a male on the right, and the green population is the general population with their risk of death by their age. And so understandably, there's a relatively low risk of death if you're in your 20s. But if you then look at your risk of death, if you're in your 20s and you have end-stage kidney disease requiring dialysis, it's markedly higher. And again, the curve here is a logarithmic scale. So we're looking at probably, but this is certainly more than 10 times increased death if you have end-stage kidney disease. So anything that we can do to reduce the risk of progression to either higher stages of CKD or to the eventual point of dialysis requiring CKD is beneficial to these patients, not simply because they miss dialysis, which is a very unpleasant thing for many patients to do, but because it will improve their longevity overall, hopefully. And so on that note, I'll introduce our imaginary patient for this evening. So this is Mr. NP. He's a 62-year-old male, and he's a bevy of vascular risk factors. He has no hypertension on candesartan 8 milligrams a day. He has dyslipidemia on atorvastatin. He's a smoker and has obesity. And so in this scenario, he's turned up for a routine 6-month review, and his blood test show is GFR is 55 ml per minute, and he's got a urinary albumin to creatinine ratio of 2 milligram per millimole, so that's within normal limits. So the question here, that I ask myself, and so whenever I see a patient who has CKD, which as this gentleman does, is how severe is this CKD, and what is his risk of progression? And there are several important factors that decide this. One of those is the underlying cause of kidney disease. If this person has an active glomerulonephritis that we're not able to manage, then his risk of developing CKD is going to be a lot higher than someone who's got well-controlled hypertension and hypertensive nephrosclerosis with the same GFR. But even if we ignore the underlying cause, what we can do is we can risk stratify these individuals based on their GFR and the extent of albuminuria. And the other thing that we can see on this graph here, where this table here, where we risk stratifying, we can see that CKD is not simply GFR. So GFR is important because that's how we most commonly stratify stages. But the importance of albuminuria can't be underestimated. So if you've got a GFR more than 60 and no albuminuria, no structural abnormalities in your kidneys, then we wouldn't consider you to have CKD. But if you're in that same situation and you have albuminuria or one of those other abnormalities, then you would have CKD, even though your GFR is normal. And that's because we know that those factors, particularly the albuminuria, demonstrate that there is some damage to the kidney, and this albumin is leaking into the urinary space through that damaged area. And where you've got some damage, there's this risk that this is going to progress. So you can see very quickly your risk stratifies quite with increasing albuminuria. So with the albuminuria here, if you've got normal levels of urinary albumin, you're going to be in that lower risk category. But even if you've got a GFR greater than 90, you're going to go up to moderate risk of CKD progression, even if you've got microalbuminuria. And if you go from micro to macro, you're now at very high risk of developing of progressive CKD. So the importance of albuminuria really can't be understated in terms of how we think about patients who are sort of coming into our clinic spaces. And the other thing that I kind of touched on here is that CKD is not purely GFR and albuminuria. If you have structural abnormalities, if you've, for example, got horseshoe kidney but normal kidney function, you still be considered to have CKD. If you've got microscopic hematuria that's of glomerular origin, then that is going to be similarly put you into the CKD category as well. So Mr. NP has a normal urinary albumin to creatinine ratio, but he does have a degree of GFR reduction for his age. So his GFR was in the low 50s, and this puts him at moderate risk for CKD progression. And so what we would do in this, well, the question I guess then becomes, what do we do for this guy? And so for a man here who's got mild risk, we need to finish our workup. What we've got here is the basic urine ACR and an EGFR, and that kind of helps us stratify where he is. But we want to extend that biochemical profile, which probably would already have been done in this case. It's a little bit contrived in some ways. So we want to see, does he have any evidence of acidemia or hyperkalemia? Should be relatively unlikely at that GFR. We want to start looking at other risk factors for progression of chronic kidney disease. What's his HbA1c? What's his blood pressure doing? But also the other factors that kind of feed into not just CKD risk, but vascular risk in general. So does he have dyslipidemia, for example? His GFR, as you can see here, so you can see here with the moderate risk group, we don't really expect to see these individuals having issues with anemia or abnormalities of the calcium phosphate balance. So they wouldn't necessarily be a group that we would need to start looking at parathyroid hormone levels or starting to worry about whether they're going to need erythropoietin or something like that. But what we should do for everyone with CKD is assess their cardiovascular risk, and we'll come on to that further into these cases. So, and the other side of it is depends on the situation. If his GFR is progressively declining, then he might be someone who needs to be referred across. If that GFR is stable and he's got normal albuminuria, he's got readily manageable risk factors, then he's probably someone who doesn't need to necessarily come across for nephrology input. However, as you can see, as we go further down that spectrum into the high risk and the very high risk, we need to start thinking about some of these other factors that can come from advanced CKD, and we will discuss those later. With these people who are at very high risk, we also need to start thinking about, are they going to progress onto dialysis, and start to have some conversations around that. But that's a little bit out of the scope of what I was going to talk about today. Most of those conversations will be happening in the renal clinics. So, in terms of this gentleman, he's 62. He's got hypertension. We're not really sure how well that is controlled yet on his candesartan. He's got dyslipidemia, and he's had some management there. He's still an active smoker, and he could probably lose some weight. And so he's come back now for a follow-up 6-month review, and his GFR is essentially stable, but now he's got microalbuminuria. He's got a urine albumin to creatinine ratio of 23 milligram per millimole. And again, now we need to start rethinking about his risk stratification. Where does he now fit? And now, as you can see, just with that change in albuminuria, he's moved from moderate risk of CKD to high risk of progression. And so we need to be a little bit more aggressive now in terms of his management and trying to get some of these risk factors under control. We also need to be a little bit paranoid here as well, that we've seen this kind of progressive rise in his proteinuria. And is this something we're going to keep seeing rise? And maybe this is a separate and new process that's impacting his kidneys. And maybe we need to potentially consider referral. So I've put this slide in because I think one of the difficult questions we get with these people is often everyone wants to know why this has happened to them. And so why do I have CKD? Why do I have this protein in the urine? And for Mr. NP, it's actually very difficult to answer that question with any degree of certainty. And the reason that is because he actually has multiple risk factors that could have contributed to this problem. He certainly could have an element of diabetic nephropathy. That's possible. He might have a degree of hypertensive nephrosclerosis as well. But he's also a smoker, he has dyslipidemia, and he's likely going to have some degree of vascular disease too. And renovascular disease, impairing renal perfusion of the kidney, is another aspect that could be driving changes in his GFR. So it's really hard to put this down onto any one thing. And so I would simply say to this man that there is a combination of factors that are probably combined together to cause this. And then it kind of also drives the discussion about how we best treat this. Well, we need to look at all of those things. We need to look at his blood pressure control. We need to manage his diabetes better. We need to look at his weight loss, smoking cessation, getting his dyslipidemia well controlled. And so what do we do about it? So for a chap who's now high risk, we need to be a bit more aggressive around lifestyle modification. And we covered some of this stuff in the hypertension lecture, but I think this SNAP acronym is quite convenient, actually. So he is a smoker, and we probably would like to have him quit. Obviously, that's very easy to say and difficult to do, but it's something where we can start to talk about this as a risk factor that has contributed to his CKD and will contribute to his increased risk of it progressing. Nutrition is predominantly at this level. We're going to be talking about sodium, so we can talk about his risk of fluid overload and his risk of hypertension, and reducing his sodium intake to ideally less than 5 grams a day. So as we saw in the hypertension series, that's going to have could potentially have really profound impacts on his blood pressure control. And otherwise, for a guy that's dyslipidemic already, managing his saturated fat intake is going to be helpful as well. At a GFR in the 50s, he's unlikely to run into difficulties with hyperkalemia. So we wouldn't necessarily restrict his potassium intake at this stage, but it's something we would just keep an eye on in the background. Alcohol reduction, the CARI guidelines recommend that we go as the national guidelines, and therefore suggest that there is no safe intake. This is a slightly older one, suggesting 2 standard drinks per day, but there is no safe intake, and it may be minimized as much as possible, although there is no specific direct link between alcohol intake and CKD risk. But again, it does have impacts for example, cardiovascular disease, and that is going to be the thing that we are going to be really mindful of in this individual and people like him. Ideally, we'd like him to be physically active. We'd like him to try and get that weight under control. All very difficult things to do, and we might even need to consider pharmacotherapy for his weight. In terms of pharmacological management, we'll do this in a little bit more detail in a mo. But we need to start looking at things that have evidence for reducing the risk of CKD progression. We need to get good blood pressure control because we've already got him with single agent therapy as it is, and we need to start considering have we got good lipid lowering therapy in place. We also need to get a clearer picture about type 2 diabetes, although he doesn't actually. In fact, I don't think he does actually have type 2 diabetes in this either. But we need to monitor for that and make sure if he does develop type 2 diabetes, it's well controlled. And so this is kind of a little bit of a follow-on from there, which says that really for all patients, they're going to, especially albuminuric patients, we're going to want to start them on an ACE inhibitor or an angiotensin receptor blocker. And so what we would really like to do is I just start most people at a relatively low dose, equivalent of 2.5 milligrams of ramipril, or 2 milligrams of perindopril, and gradually up titrate. This is an iterative process. We are not going to get in control of these risk factors in the one setting, and it's probably better that we gradually up titrate things to effect. We're going to be targeting that blood pressure with a slightly lower target of 130 on 80 millimeters of mercury, and we are going to do a cardiovascular risk assessment. And then we're going to respond to that with lipid lowering, which he's already on, and we'll cover the cardiovascular risk assessment in coming slides. And again, we need to make sure if he develops type 2 diabetes, that we get it well controlled. We'll come to the add-on therapies downstream of ACE inhibitors or ARBs down the track. But with the ACE inhibitors, these are pretty much standard for most people with CKD, although the strongest evidence is for proteinuric CKD, where they are one of our core tools for reducing risk. And they are useful on 2 arms. One is that they will help us control blood pressure, which is a really important risk factor for progression, but they'll also help to control that proteinuria. There we go. And so I like to think of this as the low stress approach to CKD optimization. So because this should be as easy as possible. And so for my approach to managing CKD in the clinic is that this is something we're going to do over multiple visits. And so with the first visit, we're either going to start an ACE inhibitor or an ARB, particularly for those who are proteinuric, or if they're already on one like this guy is, we're just simply going to up-titrate that. And we're going to up-titrate that, driving towards hitting those blood pressure targets and also proteinuria targets. So if we could normalize proteinuria, that would be wonderful. But we're looking ideally to get at least a 50% reduction in proteinuria, because we know if we can hit that target, we will significantly reduce this man's risk of progression of CKD. The other thing we need to think about too is those underlying risk factors. So in a man like NP, that blood pressure needs to be well controlled, and we're going to be targeting that with our maybe upping his candesartan in the first instance. We need to look at his weight. We need to look at his smoking. And we also need to look at his dyslipidemia overarchingly from a cardiovascular disease perspective. And then once we've got a handle on those things, we then start to look at optimizing proteinuria. And so if we optimize our ACE inhibitor or an ARB and we hit our maximal dose and there's still proteinuria, then we need to start looking at alternative options, which will be coming up. And so when I start an ACE inhibitor or an ARB, I'm always mindful that this is not something I'll be able to come back next week and check the effect of. The effect in terms of both blood pressure and also proteinuria is often delayed, and it's worth leaving it at least a month to see the maximal effect of any change in dose or initiation of new therapy. The other side of it too is the guidelines suggest that there is a reduction in GFR of less than 25% can be expected. They also state that if it's more than this, then we need to start reassessing the patient. And what we've been really considering in this situation, if they drop their GFR a lot when you start an ACE inhibitor or an ARB, is do they have bilateral renal artery stenosis, and we've impaired their renal perfusion. I personally find 25% to be a little on the high side. Anecdotally, I very rarely see someone drop their GFR by 25%. I would find that a little bit alarming. I generally find that you're seeing a little 10% or less reduction in GFR on initiation or dose escalation, and we accept that reduction in GFR because it is demonstrating that there is a reduction in glomerular filtration pressure, which is that process which is going to, over time, continue to damage those glomeruli and drive that risk of CKD progression. So whilst the guidelines do say you accept us at anything up to 25%, I'll be a little bit more cautious around that, because we generally find that we don't see those sort of levels of reduction. But it's really worth it, because if we can get someone on one of these medications, we will reduce their risk of developing end-stage kidney disease by more than 30%, and will actually reduce their risk of cardiovascular disease by at least 18%. And all those numbers are obviously fantastic, because there's very few things that we can do like this where we're going to have a sort of effect like that. So what that really means, I guess, is that the ACE inhibitor and the ARB therapy, whilst tolerated, is the mainstay of anti-CKD therapy for most individuals. So the other question that often comes is, and when we think about this too, when we see these guys, is when should we see this guy next? What is the risk that he progresses in the background whilst he's not back in clinic and we're not keeping an eye on him? And so for him, excuse me, with his high risk of progression, he's someone we should probably be seeing every 3 to 6 months. Generally speaking, anyone with a degree of CKD, we probably see every 12 months. So those people with relatively sort of mild to moderate CKD, catch them every 12 months. This guy probably every 3 to 6, depending really on how unstable he is. 6 months would often be quite reasonable for these guys. And then if he's at high risk of progression, we're talking every 1 to 3 months. And that's really the 1 month there is really when we're talking about people who have a very aggressive process going on and they've got a progressive decline in GFR. We'd probably be seeing those guys a lot more. Whereas if they've got stable advanced CKD, then they're probably someone we could maybe see every 3 months. So it's the stability in that situation that dictates how often you'd be comfortable bringing them back. And generally, every time we see these guys, we're doing blood pressure, weight. We'll be trying to drive that quit smoking campaign, and we'll be doing that renal assessment where we'll do the blood pressure, but also we're going to do the urine albumin to creatinine ratio, and a GFR on each assessment. And again, even with these guys who are high risk of CKD, I mean, he's got a GFR here above 30. The likelihood that he gets significant edema or fluid overload as a result of his CKD is pretty low. So we wouldn't get too stressed about fluid state. I generally assess fluid state for most of these guys anyway. But it would be unlikely to find that he's edematous because of his CKD. If you found edema in a chap here with a GFR of 55 and he wasn't nephrotic, you'd start to think of maybe a local venous cause or maybe congestive cardiac failure. So despite our best efforts at optimizing his care, Mr. MP comes back for a follow-up review. His blood pressure is now pretty much at target. We've had to get the candesartan now up to 32 milligrams a day to achieve this. His GFR is stable, which is great, but he's still got proteinuria. He's still got microalbuminuria. And so what's the approach here? So it wasn't all that long ago, we didn't have a lot of alternative options here. And we were doing things like adding ACE inhibitors and ARBs together in a desperate attempt to get this proteinuria down. Because we know that if we can get the proteinuria down, we will actually significantly reduce his risk of CKD progression. But we didn't have a lot of tools to do it. But now with the SGLT2 inhibitors, we do have a really powerful tool to do that. And the reason albuminuria reduction is so important is, as you can see here, the more albuminuria you've got, the higher risk of end-stage kidney disease and progressive CKD, as discussed. So what you're looking at here is people who have normal albuminuria in the bottom risk category, and where then people who are microalbuminuric or macroalbuminuric in the red. And what you're looking at down the bottom is their GFR. So as the GFR declines, the risk of end-stage kidney disease goes up, of course. It would be 100%, less than, well, it'd be close to 100%, less than 15. But what you can see is actually this then stratifies up your risk of having end-stage kidney disease, even if you've got a normal GFR, but your macroalbuminuric is markedly higher, 16 times higher than if you had normal albuminuria. And we see similar things here for progressive CKD and even acute kidney injury, although the association is less strong for AKI. But the other thing that we need to think about as well is albuminuria is not simply a marker of glomerular abnormality. It is a marker of endovascular dysfunction as well. And it is a marker actually of cardiovascular risk. And so we see a similar pattern, albeit not quite as strong, in both all-cause mortality on the left and cardiovascular mortality more strongly on the right. And so again, what we see here is if you've got a normal GFR, but you've got macroalbuminuria, you have a 4 times increased risk of cardiovascular death. Can take into account all of your other risk factors compared to if you just had normal albuminuria. And so you can see that actually reducing, if we can control urinary albumin excretion, we not only will protect people's kidneys going forward, but actually we can really significantly start to reduce their risk of cardiovascular death. And so coming back to the case here, Mr. MP, because he has CKD, and he is on an ACE inhibitor, and he's on a maximal tolerated dose, he qualifies under the PBS criteria for an SGLT2 inhibitor for CKD specifically. And so he qualifies for this because across these various visits, he's had CKD now for 3 months or more. He has a GFR of more than 25 and less than 75. He has a urine albumin to creatinine ratio above 22.6. He's not had a kidney transplant or dialysis, and he's now stabilized on this ACE or ARB now for more than 4 weeks. And the important thing to recognize here is, yes, SGLT2 inhibitors are great for treatment of diabetes and for management and prevention of diabetic nephropathy, but you don't actually have to have diabetes to access these anymore. You can access them from a heart failure perspective, but also you can access them purely for CKD here. So in this gentleman who does not have type 2 diabetes, my next step would be to start him on an SGLT2 inhibitor with the aim of further reducing that proteinuria. Oops. There we go. And so the approach here when we're trying to reduce proteinuria, we've kind of touched on. We go ACE inhibitor and ARB, we bring that dose up to either the maximal dose or the maximal tolerated dose. If we still have proteinuria, we add an SGLT2 inhibitor. I prefer dapagliflozin because it's once a day therapy. Empagliflozin, it's a little bit less convenient for people to take. The other side of it too is you've got, if you still have proteinuria beyond that, there are now further alternative options. We used to use spironolactone a little bit because there was some evidence around that, but there's increasing evidence now for finerenone, which has the same mechanism of action. It's an aldosterone inhibitor. So that works essentially on the same pathway as the ACE inhibitors and the ARBs, but it's working a little bit further. Is working in a different part of that signaling cascade. So we now have quite a few options that we can look at. The issue with finerenone and drugs like it is that because they are inhibiting the mechanism of action of aldosterone, you do have this increased risk of hyperkalemia, especially when you're already talking about someone who's on an ACE inhibitor or an ARB. So generally speaking, we'd be making sure that people have a potassium of less than 5 before we'd be starting something like that. But now you can see we've got a graduated approach to getting this proteinuria under control. And so when I originally did this, I had him on ramipril, but he's on candesartan. So we increased his candesartan dose. He's now on maximal dose, and that's helped with his hypertension, but it's also helped with his proteinuria. But we still need to get that albuminuria reduced by at least 50%. And we know that, as I was saying, even reductions of 30% albuminuria will reduce the risk of end-stage kidney disease by 32%, which is massive. So it's really a target we should be pushing hard for if we can. All right, and so why would we consider an SGLT2 inhibitor in a chap like this? Well, there's a lot of data now demonstrating their benefit in end-stage kidney disease, in chronic kidney disease. We are very cautious around these in terms of sick day management and things like that, and I will touch on that. But overall, they have a significant impact on reducing that risk of development of advanced CKD, specifically end-stage kidney disease. And so this was one of the earlier studies looking at CKD progression in patients given dapagliflozin. And what you can see is the dapagliflozin in the blue separates from the placebo arm at around the 8-month mark in terms of that risk, and then progressively stretches out. We also see that it also reduces the risk of cardiovascular death and hospitalization for heart failure. And that's obviously really important for our cohort as well. But the thing to consider about SGLT2 inhibitors is kind of captured in this slide here. And so when we start, we were talking about with ACE inhibitors, we could expect that GFR to drop a little bit when we start them. Like I say, I don't often see a very significant drop in GFR when we start the ACE inhibitors, but we do see that more often when we start an SGLT2 inhibitor. And so what happens when you start your SGLT2 inhibitor is there's going to be this expected drop in GFR. So you can see here in the dapagliflozin arm in this study, the GFR actually drops initially below the placebo group's reduction in GFR, and it doesn't get out until 12 months later where they're back on par again. And so you would think this is a terrible thing. We know from the previous slides that the lower your GFR, the higher the risk of your progression of your CKD. But because it's really significantly reducing your proteinuria, what happens down the track is that reduced glomerular filtration pressure, that reduced albuminuria, actually your risk of CKD progression starts to drop away. And those who are on placebo have an increased reduction in their GFR over that time. And going up to 3 years, they're starting to really significantly separate. And they seem to be continually separating out further. And so it'd be fascinating to see the longer term follow-up data on this at that point. And so this is why we use drugs like dapagliflozin, because in the long game, which is really the game we play with CKD, these drugs seem to be really powerful at reducing that risk of progression in the proteinuric patient. The other thing, and I won't spend too much on this because we did kind of cover this sort of a month or so back when we did hypertension. When we're optimizing blood pressure for patients with CKD, we are really targeting that less than 130 on 80. And that's data coming out of the SPRINT trial and trials like it, where we know that patients with CKD, when we finally started to include them in some of these trials, do a lot better with aggressive blood pressure management. They do have a slightly increased risk of AKI, but in terms of CKD progression over time, they do better. I kind of think of it like an SGLT2 inhibitor or an ACE inhibitor. It's a double-edged sword. There is this risk of AKI, but for most individuals who tolerate them well, they will tolerate aggressive blood pressure reduction, and it'll be beneficial down the line. The other side of it, we kind of touched on this already, it's like the proteinuric effect. The antihypertensive effect of these drugs is delayed. So there's no point bringing people back too soon to reassess how they've gone, unless their blood pressures are, very high, and we're concerned we need to get them down faster. But these are the sort of people I bring them back every 3 months if they've got, reasonably significant CKD, and just keep nibbling away at that blood pressure control over time. Patients seem to tolerate that better as well. Rather than having more aggressive reductions in a short time, we can achieve a more impressive reduction in the longer term, and they seem to tolerate it better. And then also, we may need to consider drug options where we can reduce polypharmacy by combining drugs that have combined products, for example, where you might want to start someone on 2 drugs that then you can put them on a single product and give them one tablet once a day. I know that most individuals struggle to take. The more times a day you take a tablet, the less likely you are to take it overall. And so if you can take something once a day, you're much more likely to be compliant over the course of time. And again, ACE inhibitors are obviously the first line therapy. And then most people would throw in a calcium channel blocker or a thiazide at that point. We're moving a little bit away more from thiazides in CKD. They're great for hypertension, but they may not be quite as good at reducing that risk of CKD progression. So calcium channel blockers have kind of slipped in there as probably the first choice second line agent. And then we've got all the other options down the track, beta blockade, and then things like spironolactone or eplerenone, if we're thinking about targeting proteinuria further. So to come back to our patient, so Mr. NP now comes back again. The last time we saw him, we were a bit worried about his proteinuria, and he was on his candesartan, and we were putting him on some dapagliflozin at that point. He's back now. His GFR has come down a little bit. His GFR is now in the high 40s. But his UACR has normalized or near normalized now. And so how do we actually go about reassessing his cardiovascular disease risk? We've looked at how we manage his CKD risk, but what about his cardiovascular risk? Because this is something I like to try and do in the background of these visits, is start to assess some of these things so that we can bring in therapy and do sort of 2 things at once where possible. So the best way that I know to assess cardiovascular disease risk in the clinic is using the cvdcheck.org.au calculator. So this is available free online. Patients can do it themselves if they want to, but I find often just it takes about 20 seconds to do if you've got the data available. And if I've got the time, I will do it with the patient present, and I will take them through and I'll show them that their risk is at the end, put in their data, and then you can show them if, for example, we drop your blood pressure from 145 to 120, we can show them what the change in their in their cardiovascular disease risk would be. It's important to note that right at the top here, one of the key risk factors for having a high risk of cardiovascular disease is moderate to severe chronic kidney disease. I know we've kind of touched on this. I keep coming back to this cardiovascular death as being a significant concern for our patients. So moderate to severe CKD equates to stage 4, stage 5 CKD, a GFR of less than 30. So if your patient has a GFR less than 30, they're already high risk for CKD. And that risk is approximately the same of having a myocardial infarction as someone who's actually had a previous myocardial infarction. So it really kind of puts into perspective the impact that chronic kidney disease has on these people's hearts. So anyway, so for this gentleman, I put this data into the figure. I've cut it off for the sake of space. And then what you get is this feed out at the end. And it tells them their risk as a percentage, and it shows them on the colored bar at the bottom where they fit. So what this shows is that for Mr. NP, he has a 10% risk of having a heart attack or a stroke in the next 5 years. And so it shows you this picture of 100 people, and he's, 10 of people just like Mr. NP are going to potentially have one of these events. And I find that this is reasonably motivating for a number of people, because it kind of puts that risk in a tangible way that people can feel. I can tell people all the time that we've got to be careful. They might they have a higher risk of having a heart attack. But I find that when it is displayed like this, when people kind of think about, geez, I've got a 10% risk of having a heart attack in the next 5 years, that really starts to bite. And that's when you often get a bit more buy-in, I've found, in terms of managing some of these risk factors, especially when you can then take it back and say, well, hey, look, if your LDL cholesterol was 3 and your systolic blood pressure was 120, then actually maybe your risk factor would shift from maybe 10% to maybe you come into the intermediate category. And so people can see a tangible potential benefit there. And I find that really useful. Though you do have to be able to find the time for it, and it's tricky. The CARI guidelines, which I've just flicked up at the bottom. So this is kind of talking about cholesterol lowering therapy. And so anyone who has a cardiovascular risk of more than 10% should be considered for lipid lowering therapy. And anyone who is an Indigenous Australian or a Maori person should actually have a lower threshold for going after lipid lowering therapy. So if you had a 5% risk as an Indigenous Australian, you would need to really consider getting that risk down. And that's because Maori individuals and Indigenous Australians do have this sort of increased risk at baseline of having cardiovascular disease, and therefore we need to be a little bit more careful around how we manage their risk factors. And so it seems relatively straightforward. This guy is high risk. We should be looking at primary prevention of cardiovascular disease for Mr. NP. But in chronic kidney disease, this is quite tricky. And the reason it's tricky is we really don't have all the studies that we would like to make this a little bit clearer. So we know that all these people have a high baseline risk. And we know from many studies in people who don't have CKD that statins are really, really useful at reducing cardiovascular disease risk and actually probably all-cause mortality overall. But the best data that we have in CKD, we don't actually have targets for lipid lowering. One of our best studies essentially just looked at the benefits of a fixed dose simvastatin plus or minus ezetimibe versus placebo, and that was actually that was a very useful intervention. It did reduce cardiovascular risk, but we're talking about a very blunt approach to lipid lowering relatively to some of the cardiology studies that we've seen. The other side of it too is that we're kind of getting into the sort of amorphous, touchy-feely side of the evidence a little bit now, and this is a possible benefit for atorvastatin over some of the other statins, because that has been shown to perhaps have an impact on reducing proteinuria and CKD risk. So some people choose atorvastatin over others for that purpose. It also has there's also less impact of chronic kidney disease on the complications of statin use with atorvastatin, whereas some of the others may actually have an increased risk of statin myopathy. And so what's my approach? Given the evidence in this situation, Mr. MP probably should be on lipid-lowering therapy. I personally use atorvastatin, not because I think it's necessarily better. I think the evidence on that is still weak. It probably all statins realistically are at a comparable dose, are probably doing the same thing. And I started atorvastatin and I started at 20 milligrams, and I don't drive after particular cardiovascular targets for primary prevention. When we're talking about secondary prevention, then we've got all that cardiology evidence to say, hey, actually maybe we should be going for really tight cholesterol control. But at this stage, it's a little bit amorphous. These guys probably do need some therapy, but we don't really know once we've started it whether we should be escalating those doses or not. So I simply put it on, and I don't push hard unless something else drives my decision making in that way. The other side of things in terms of managing risk factors for progression and also risk factors for cardiovascular disease is type 2 diabetes. This is kind of the one-off slide here just to talk about that, because this, well, sorry, there is a follow-up slide. This is a bit tricky because a lot of the things we'd like to treat people's diabetes with are renally excreted or have an impact on kidney function. And so for those who have a GFR more than 30, the first line therapy is still metformin, and the first add-in therapy is probably going to be an SGLT2 inhibitor if we haven't already done it from a proteinuria perspective. And beyond that, we have the GLP-1 agonists, which for many of our patients with CKD has the potential benefits of weight loss, and they may also have benefits in terms of CKD progression themselves, although that is still something that we need to tease out. They do, though, have established cardiovascular benefits. And again, this is a really important factor for our patients. So they are a very good third option if we can ever get stock of them. The sulfonylureas are tricky. So we need to be careful about the sulfonylureas in reducing GFR. So below 30, we probably shouldn't use them. We can, with caution, use some of them, but they start to accumulate. And because they drive insulin release, we have this increased risk of hypoglycemia. So we can tolerate them if they're needed. We just probably need to monitor those blood sugars a little bit more carefully. And of course, we're targeting a HbA1c of less than 7%. That's a target of less than 7% has improved outcomes for microvascular disease in general, so retinopathy, peripheral neuropathy, and of course, from our perspective, diabetic nephropathy as well. So if we can get that HbA1c less than 7, then we're in a pretty good place. And of course, we have insulin up our sleeve. Insulin is obviously very effective. It obviously does promote weight gain, and so it's that double-edged sword. But many of our patients do end up needing insulin. It's one of these sort of cruel things of advanced CKD is as your kidney function drops, your clearance of insulin also drops, and so people finally find their diabetes gets a bit better controlled as their kidneys fail.
It's not so good.
No, it's not so good. No, it's not really an upside. And so really briefly, so this is looking at oral hypoglycemics in CKD. So we've got the only biguanide available, metformin. As your GFR gets less than 30, you can still use metformin at quite low dose, but we need to be careful. So it's careful monitoring here, and it's not monitoring for renal function because metformin, again, is not nephrotoxic, but it is renally cleared. So as that GFR drops, it will accumulate. And the thing that we worry about them getting actually at this point is metformin-induced lactic acidosis. Below 30, it's, for me, the monitoring requirements start to get a bit iffy. So unless they're getting really good benefit from it, I generally stop it below a GFR of 30. With the SGLT2 inhibitors, they're both about the same point. So the GFR less than 30 for empagliflozin or less than 25 for dapagliflozin. If you're on dapagliflozin and your GFR drops below 25, you can theoretically continue on it from a PBS perspective. But the lower your GFR is, the less effective it is. So there's going to be a point there we probably want to stop it anyway. You've got, with your GLP-1 agonists, most of them can be used down to a GFR of 15, which is quite useful. If you're using a DPP-4 inhibitor, linagliptin is super convenient because we can use that in dialysis patients and we don't have to dose adjust. So that's our favorite DPP-4 inhibitor. And in terms of the sulfonylureas we talked about, as that GFR drops below 30, my approach is if we can, we stop them. But if we need to continue on, we might just need a dose adjust. And if we're on glycoside or glipizide, those are our lowest risk sulfonylureas and probably the best way to go forward from that side. Sick day management. So sick day management in CKD. So when I think of sick day management, I'm thinking about one of these things. Patient is either nauseated or they're vomiting or they have diarrhea such that they are unable to maintain their fluid intake, either because they're vomiting up or they can't keep up with the diarrheal losses. They've either got, or they have anorexia, so they're unable to drink, or they have high fevers, and actually they're going to have more insensible losses, and they may not drink as much either. And really, in that setting of sick day management, what I'm really talking about is people who are at high risk of getting dehydrated and getting a pre-renal insult to their kidneys. And this is important because there are a number of drugs that we really like to use in CKD that can become problematic in the sick days like this. One of those we just touched on is metformin. We can start to see that accumulate as the GFR drops, as people are unable to maintain hydration. And then there's that risk that people acutely present with a metformin-induced lactic acidosis, which can be quite severe. So generally speaking, for all of these drugs, the suggestion would be that they be withheld where able. If people, so what I tell my patients is, if you develop a condition like this, you should hold off that medication. And if it's lasting more than a day, then you should go and get reviewed, because in that situation, you're talking about people with CKD already. Their risk of AKI is quite high, and therefore they are going to probably need rehydration in some way if it's going to persist. But otherwise, those things that are renally excreted, like sulfonylureas, if they accumulate, you're going to get this significant increased risk of hypoglycemia. And then it's the things that are going to make your risk of AKI higher. So we should discontinue the SGLT2 inhibitors, the ACE inhibitors, the ARBs, the spironolactones of this world, and diuretics in general, because these are going to exacerbate that problem. We're already getting a pre-renal insult, and part of the way that these drugs work is either by, in the setting of case of diuretics, reducing your hydration state, or in the case of the other two groups, they are reducing glomerular filtration pressure, and that's already now impeded because we're not getting enough blood flow into the kidney. So these are the things we need to think about as people are getting sick, and then as they start to improve and they're eating and drinking again, then they can go back onto these. So in terms of a quick summary of general management principles, smoking cessation, obesity management where possible, targeting proteinuria, getting type 2 diabetes well controlled, and managing hypertension, and then that medication management risk. This is reminding you about addressing blood pressure targets and reducing the risk of CKD. And then really briefly, one of the other things that we do more often through the renal clinics is targeting metabolic acidosis. So metabolic acidosis through all these mechanisms here actually increases your risk of CKD progression. So generally speaking, we try and get a serum bicarbonate above 22 for these people, and that's simply with oral Sodibic replacement. And of course, we're monitoring for hyperkalemia. And this is just showing you that as that sodium bicarbonate drops, you have this increased risk of progression of CKD. And at the other end too, we do see the opposite effect. So there seems to be a sweet zone in the middle there. We don't want to increase it too much, but we do need to try and get it up. Very briefly, because I think we're into the last sort of 5 minutes now, I was going to talk about some of the things that we get with more advanced CKD. Sort of more prominently, we're seeing these issues in CKD 4 and 5. So you guys will obviously be seeing these patients in your clinics as well. And when we're getting GFRs down like this, obviously as CKD progresses, our ability to clear a number of drugs reduces. And so we need to start thinking about dose reduction, probably as we're starting to hit stage 3 CKD, but really starting to get heavy on that as we're entering stage 4. We have issues with acid-base balance and fluid and electrolyte homeostasis. So people start to retain fluid, which can cause other problems, including contribute to their congestive cardiac failure risk. And obviously, we're always worried about hyperkalemia. We have anemia of chronic kidney disease because of a number of factors, which we'll discuss in a mo. We sort of lose our ability to properly regulate blood pressure as CKD progresses. And of course, CKD affects calcium phosphate and then bone health as well. And so I was going to pick two of these. I was going to look at anemia and bone health very quickly. And so anemia, and I'll move through this relatively quickly. Anemia in CKD is not purely a deficiency of EPO. So erythropoietin is made in the kidney predominantly, and that is a driver of anemia in these patients. But actually, one of the major issues is iron deficiency, because CKD drives this pro-inflammatory state. We get this increased release of hepcidin, and we're unable to absorb iron, and we're also unable to release it from stores. So our patients can be truly iron deficient, and they can also be functionally iron deficient, where they actually have a normal ferritin, but they are unable to access it, which makes their management quite a whole lot more difficult. But one of the key things, particularly for dialysis patients, we're always worried about is making sure we're maintaining iron stores, because without those iron stores, we won't be able to generate new red blood cells, even with the addition of an erythropoiesis stimulating agent. We get a reduction in erythropoietin production, and we also get EPO resistance from that inflammation as well. And because we start to accumulate renal toxins, urinary toxins, we get a degree of bone marrow suppression. And all this feeds into a reduction in erythropoiesis. So we get a reduced ability to make new red blood cells. Just to make life more complex, that inflammation also drives reduced red blood cell survival. So we're making less red blood cells, and they're not lasting as long. And so it's very common that we see patients develop anemia in this setting. Having said that, the common causes of anemia in CKD are the same ones that you see in all your other patients as well, with these couple of additional issues. Iron deficiency is actually probably the most prominent driver. And so for the patient that's anemic with CKD who's iron deficient, we correct the iron deficiency first and see how they respond to that generally. Erythropoietin deficiency and resistance is obviously there, and we can treat that, but it's a really slow process. So when we start something like a darbepoetin to treat this, the effects of that dose initiation or that dose change is 4 to 6 weeks down the line. So if someone's severely anemic now, they're actually going to need a blood transfusion, because the darbepoetin won't actually help for a long while. And then standard nutritional deficits, B12 and folate, we need to consider. We see those a lot less now in the dialysis population. And then thinking about blood loss and hemolysis. Uremic patients are more likely to bleed, and actually a number of our patients we see suddenly have a drop in hemoglobin. And there's this question about whether they need a bit more DARB, but what's actually happened is they've had a slow bleed from somewhere, and we need to stop that, because you can keep thrashing them with the DARB from the other end, but you're always going to lose that battle until you've controlled the source of bleeding. And then lastly, what this shows is that if you're looking at stage 3 CKD, stage 4, and stage 5, that we do see varying degrees of anemia. So this is looking at hemoglobin less than 120, less than 110, and here less than 100. And so you can see that at stage 3 CKD, a lot of people have a hemoglobin that's less than 120. In fact, the majority of people do, but very few people have a very low one, less than 100. And that group of less than 100 progressively increases as CKD declines. And that's really important, because our target hemoglobin in advanced CKD, so stage 4, stage 5 CKD, is a lot lower than you might think. The data suggests that when we use things like darbepoetin, if we push that hemoglobin too high, these guys have difficult to control hypertension, and they have an increased risk of stroke. So we target a hemoglobin somewhere between 110 and 120 with the DARB. And if it's going too high than that, we actually will stop it and let it come back to that range. So our targets suddenly change as well. The other thing, very briefly, because I am probably out of time.
Battery running.
Oh no. The other thing around this as well is, as your GFR declines, you develop a secondary hyperparathyroidism, and that kind of happens even at relatively high GFRs, you can see here that things like FGF23 changes and changes. Sorry, you're okay.
Sorry.
And so you can see changes, for example, in purple here for vitamin D concentrations. You can see even at a GFR of 60, it's starting to come down slowly. And then, of course, this is active vitamin D because the 1-alpha hydroxylase is predominantly found in the kidney. And therefore, as functional kidney mass is lost, our ability to make active vitamin D declines until we get to a point where actually we have very, very low levels. But many of these things happen right out here at CKD levels that we normally wouldn't think about as causing problems. Definitely below a GFR of 30, though, we're starting to really struggle with secondary hyperparathyroidism and then tertiary hyperparathyroidism. And this is mostly driven by phosphate retention and our inability to make active vitamin D. So this drives low calcium because it precipitates with the phosphate, and we can't get enough of it in without the vitamin D. And then this is the major driver for hyperparathyroidism. And hyperparathyroidism is important, and because this sort of chronic CKD mineral bone disorder is not purely about the bones. We do know it is. They have these increased risk of fractures and these increased risk of multiple bony abnormalities as well. But we see the laboratory abnormalities in terms of phosphate and calcium. But the thing we actually worry about most strongly for these guys is vascular calcification. So if you look at this X-ray of someone's ankle, the incidental finding you can see is that their peripheral arteries here are outlined beautifully in calcium. And the problem that we have with our patients as they develop advanced CKD is this also happens in their coronary arteries. And the cardiologists hate this because it's not like a standard atherosclerotic plaque, which is easily stentable. They often have long segments that are poorly managed. And once this starts to happen, these patients do relatively poorly from a cardiovascular disease standpoint. And that's why we really want to get on top of that, using active vitamin D in terms of calcitriol to overcome this issue, bind up our phosphate through a low phosphate diet and our phosphate binders, and then targeting some of these things more specifically, including surgically removing the parathyroids where we need to. That's generally something that we would drive. And then there's all the other things that we like to do, like optimize their dialysis and really get these guys over to transplant. Because if we go back a little bit, what you'll see here is that once you get transplanted, all these problems start to improve significantly. So really for these guys, if we could get them off dialysis in some way, then they'll do a lot better. But as they start to head towards dialysis, we need to get these things controlled. Awesome. That was all I had.
That's very good, Tom. And once again, such a comprehensive talk, and I learned so much. There's hopefully some answers, hopefully some questions coming from the audience. So I do would like you to put your questions into the chat box. Kunal, I can't quite see the chat box yet. Can you share that with me so that I can see? In the meantime, Tom, there is a couple of things that I was wanting to know. Some of them are a bit dumb, I'm sorry. Anyway, I was wondering, as you were talking with the albumin, what's the best way for measuring it? So generally I would do a spot urinary microalbumin. Is that sufficient, or do I need to do a timed collection each time? And how often would I do it timed as opposed to a spot?
Yeah, it's a really good question, actually. Not a silly one. Also, so we are now moving predominantly to using a spot urinary albumin to creatinine ratio. And the rationale there is that with albumin, with 24-hour collections, they are probably the gold standard when they're done well. But the truth is they're almost never done well. Patients really, it's really difficult for patients to do the full collection, so you often get an under-collected sample, and so it's much more convenient to a spot sample, get that UACR done for UPCR, and that is probably overall a better way of doing it. So I very seldom order 24-hour urine collections anymore, and that's more around the sort of stone management now rather than proteinuria.
Okay, so I can see some questions coming up. So Anonymous has asked, if you have a UEC but do not have a UAC result. Do urinary dipsticks for protein have any role in estimating CKD? That's a good question.
It is a good question. Yeah. So the dipstick is a reasonable screen to start. There are a couple. It's not as sensitive as using a UACR. So it maybe in the first instance, if you've got it. So, for example, sometimes when we're triaging them, if there's a dipstick there, I'll use the dipstick as a triaging tool. But when you're starting to look at it more deeply, you're going to want to get something a bit more accurate, and that's where your albumin to creatinine ratios would come in. The other thing also to keep in the back of the mind about the dipstick, and also the urine albumin to creatinine ratio as well, is that they only pick up albumin. So if you have proteins there that are not albumin, and it's quite a small print stuff in some ways, but for example, multiple myeloma kidney, where you actually potentially miss those people if you've got a dipstick, and then you find it on the protein. But yes, it's not a bad initial screen.
Okay, yeah. So the next question from Rabina is, what about patients who have a raised urine ACR with normal EGFR? How do we approach these?
Yeah, so they would still be considered CKD, and depending on how much that's raised, they actually might be at significant risk of progression. So if they've got a bit of microalbuminuria, I would still, and it's persistent. If you've tested it, and it's still there on repeat testing, then I would actually start to treat that, because it will reduce their risk of progression, even though at the moment their GFR is normal. Over the course of their lifetime, they might start to develop change. The other side of it as well is it's also worth keeping an eye on that, because if you're finding that starting to rise progressively, then it might be a sign actually you've got a more aggressive glomerular process there, and it might be something we need to start looking at.
So maybe an earlier referral than late.
Yeah.
Okay. So the next question, I actually was also going to ask this question. So what's your approach to proteinuria, please, in an 80-year-old hypertensive urinalysis of protein? I have lots of patients like this who are, my population is skewed to above 80. And, how aggressive do we need to be in this population?
So you're balancing, I guess what you're balancing here is risk of CKD development that's going to be a problem to the patient over the course of their lifetime. And for an 80-year-old, if you think about our average life expectancy now in Australia is about 86. An 80-year-old may go a little bit longer than that because they've got that far. You can say, okay, well, what is their risk of progression in the next 10 years? It's probably relatively low with a GFR of 86 and 1+ proteinuria. So if they needed, if they had pretty high blood pressure, because that's going to drive into their cardiovascular risk, as is their proteinuria, I would actually still look at bringing it down, as long as they weren't going. I wasn't going to get them to a point where they're starting to get posturally dizzy and contribute to the falls risk. Because the thing that's probably still on, if you were a betting person, going to kill you as an 80-year-old is going to be cardiovascular disease. So if you can reduce that risk,
something, Tom.
You do. But if you can push it out a little bit, all the much better. So I wouldn't go aggressively after these people, but I would still look at reducing that if it was safe.
Yeah. I mean, I think a GFR of 86, to me, that's high.
Yeah. And
not at all. So, I mean, a lot of mine would be, say, GFR under 60, maybe even under 50 with this sort of scenario.
And their risk of progression is, in their lifetime is still pretty low. And so I think even for those ones where you've got that lower GFR, that proteinuria reduction might be more around their sort of vascular health. Yeah. And
do you want to see them in the clinic when they're 86 and their GFR is 30? I've got lots of them if you want them. I don't send them.
Not if they're stable. Because I think those people are well managed in general practice generally. If they've got issues that need some input on, they're actually reasonably healthy otherwise, but they've got lots of proteinuria or difficult to control hypertension, or their CKD is progressing, and we're worried, can we prevent them from heading towards dialysis, then those people probably.
Okay. Yeah. So the next one is 54-year-old hypertensive diabetic on treatment with a urine microalbumin 84 milligrams per millimole. Does this need to be referred to a nephrologist?
So it would partly depend on their GFR to some extent, and also in terms of how far we've gone with management. This is someone I wouldn't mind potentially seeing, because what you're describing here is someone who is persistently macroalbuminuric. So they've got they're making 840 milligrams per day there in terms of their urine albumin production. So their risk is sort of shifting further up. They're not nephrotic range, but it's better that we don't wait till they get to that point. So that's probably someone we would be happy to see, particularly if they're already on an ACE inhibitor, especially if we've already considered SGLT2 inhibitors. And particularly if this is the other thing that makes me nervous about diabetics too is there was a great study more than 10 years ago now where they looked at nephrologists' ability to predict diabetic nephropathy. And what we found was that in about 16% of cases, there was either something else or something else in addition to diabetic nephropathy. And so for those ones that aren't responding to standard therapy, then I'm going to be a little bit careful around maybe there is something else there too.
Okay. Toaston wants to know which is better or preferred, the ACE or an ARB?
We have no data to suggest one is better than another. So my approach is to go with something that I am comfortable doing. I generally just start with an ACE inhibitor. If they get a cough, I put them on an ARB. But it really is patient dependent from a tolerance perspective and prescriber dependent from what they're comfortable with. Either one is fine.
Yeah, okay. And then I think it's Rabina again who asks, if the patient has both diabetes and CKD, then is the LDL target needed to be as low as 1.8?
So
cardiologists want that, don't they?
They do. So the CKD at this point doesn't change your target. So your target will then be based on the diabetes and also their cardiovascular risk. So if they already have coronary artery disease, for example, then that 1.8 target is going to be, the cardiologist is going to be driving for that. I'm not sure if we would target that necessarily in someone with diabetes as primary prevention. But I may not be up to date on that in that case. But yes, so for example, if one of my CKD patients had coronary artery disease, then we would adopt the cardiologist's target of probably 1.8 LDL.
Okay, and then Rebecca would like to know, young male patient with microproteinuria, no risk factors for CKD, normal GFI, high muscle mass and high protein powder and CK intake for the gym. There's a lot of young men out there like this. Would the supplements be the cause of this proteinuria?
They shouldn't be. So we see a few people like this through the clinics, particularly with elevated creatinine normally in the case of these guys who are using creatine supplements. So in terms of protein powder, that shouldn't change the amount of filtered protein. That shouldn't exclude. Unless there's a defect in that sort of glomerular filtration barrier, you should be able to retain the protein no matter your intake. So for these guys, there might be something else that's driving that. And you're looking at a young, seemingly probably fit person with nothing else going on besides the microproteinuria. It might be something where you could simply watch it and see if it's progressing, if it's quite mild. Otherwise, if it's a bit higher, then it really remains an unexplained issue at that point because it doesn't seem to have any other risk factors. It might be one that's either worth treating, or even if it's if it's really quite low, then monitoring, and if it's increasing, then sending across to us to have a look. So that's a bit of a weird one, I have to admit.
And are the protein powders bad for people? Try and tell my young sons that. Don't need them.
So answering strictly as a nephrologist to start, I guess. So I actually get this question a lot these days, which is should we restrict protein for CKD? So for proteinuric CKD, there were quite a few trials that initially showed that if you restricted protein intake, people did a lot better from a kidney function perspective. And that actually holds up over the data that if you restrict protein intake, your decline in GFR will be lower. But unfortunately, those people on those trials, those patients restricting proteinuria got more generalized malnutrition and did worse overall.
Which is not good.
So we don't strictly restrict protein. In terms of protein intake, my approach to these guys is most of the time, unless they're a competitive bodybuilder, the amount of protein some of these young guys are intaking is probably just making them have expensive urine with quite a few amino acids that they're not actually using. So I'm more approached from that side, that they might actually just be wasting their money rather than being a health issue.
Eat more eggs.
Yes.
And just got one more question. So an 80-year-old, GFR 34, recurrent UTI, ultrasound, I think that means, showed small for age kidneys. What to do next?
So I think there are two separate issues here, probably. So one is the recurrent urinary tract infections, which is probably a separate issue on its own. Urinary tract infections, generally outside of sort of specific instances where we're talking about more sort of reflux nephropathy in a young person, probably don't contribute to CKD development, realistically. But recurrent urinary tract infections, we need to start thinking about, is there an abnormality of the urinary system that is contributing to this a nidus of infection, or there's some sort of abnormality that's mean we're getting reinfected continually.
Do you mean like a cyst or something?
A cyst, or maybe a diverticulum in the bladder, or sometimes we find that someone's got an infected stone, for example. So those sort of things to consider. In an 80-year-old, you're not really going to find probably anything congenital, obviously, but there might be something else there. In terms of the kidneys, so GFR of 34, if that was stable and their kidneys were small and they didn't have proteinuria, then I would be comfortable, as long as I would just look at their risk factor management at that point. In general practice, would probably be good. If they've got difficult control risk factors, or they've got a lot of proteinuria, then that might be something where we need to think about it. But given their kidneys are small, what's probably happened here is that they have had insults to those kidneys over the course of their life from probably comorbid disease, and that has caused a CKD. So it's not likely going to be one where we're going to find some reversible underlying component. It's going to be more about managing those risk factors to reduce the risk of progression.
Does long-term hypertension cause small kidneys?
Yeah.
Sclerotic.
So any process that's damaging will eventually lead to them. But classically, the opposite happens in early diabetic nephropathy. They get bigger kidneys, but everything kind of ends up small and shrunken atrophic.
Excellent. All right. Okay, so I think that's bringing us to the end of our questions, and we're just on just past 8:45, so I think we've done really well with time. So many takeaways from this, Tom. Now I've learned a lot. I think everybody's probably learned a great deal. I know I'm going to try and tighten up the management to some of my patients that I've got out there. So thank you once again for taking the time to do this week's presentation. We will have our third webinar. I think it's July. It's scheduled for, and we're going to be talking about what are we doing? Prescribing in CKD and deprescribing in CKD. So we look forward to seeing you again. I think it's the 1st of July. That's what's written on here. So anyway, I'm sure an email will have gone out to everybody to check to register for that. So please do register. Please remember to fill in the evaluations. Your feedback is very important to us. So thank you once again for attending, and good evening, everybody.
Thank you for coming.